today, okay? All right. This is some information about the CE part of this presentation, and Sydney will be showing more about this later, but they wanted me to make sure that this was a part of the presentation. Not going to spend time on that. So today we're going to learn about key components of value-based care models related to community pharmacies. We'll also learn about a couple of value-based care models that we implemented and evaluated in Iowa. The first one, I was involved a lot with the evaluation, and the second one less so, I have less information on that one. But I still think it's a useful thing for us to discuss. And then finally, we'll discuss some lessons learned from these value-based care models in community pharmacies. So for the past, 20, 30 years, our healthcare system has been trying to improve by addressing the triple aim of better patient outcomes, positive patient experiences, and limited healthcare costs. I'm not going to get into the history here, but we've tried a variety of mechanisms in this country, and value-based care is one currently being used. While value-based care contracts are used for payments for many different types of healthcare services and providers, today we're going to focus on how these models are being used in community pharmacies. And then another thing I just want to point out, it's really been driving a lot of action, I guess, in the community pharmacies, good and bad, I think. Community pharmacies are seeking revenue streams, from care services to offset losses they are experiencing from dispensing due to unregulated pharmacy benefit managers, PBMs. I'm not going to spend time on this, but it is a real issue for these pharmacies to continue to stay open. And so having these value-based care contracts and programs, I think is important because it provides some revenue that can kind of keep their business going. So as I mentioned, value-based care models typically focus on provider performance, patient experiences and outcomes, and then the cost of care. Typically, payment is at least in part tied to provider performance on a set of metrics. For community pharmacies, we see metrics such as a 90-day fill rate, medication adherence measures, statin intensity. There's a range of them, comprehensive medication review rate. These value-based care models are being used by government payers such as Medicare Part D plans. Some state Medicaid managed care organizations are using them as well. And then commercial payers have really started to get on board with them. I want to talk about 4 components for value-based care models: attribution, performance measures, incentives, and patient care services. So let me just kind of work us through each of these. So attribution in pharmacy value-based care models refers to assigning patients to particular pharmacies so their utilization data can be used in calculations for that pharmacy. So there typically is some type of performance calculation that is used in payment. And so the payers need to know which patient's utilization should be assigned to each particular pharmacy. And so attribution is important, can be done prospectively or retrospectively. Often beneficiaries are attributed to the pharmacy that dispenses the most prescriptions for that patient. So I guess the idea is the pharmacy is already taking care of that patient to some degree, And so that makes sense to attribute him to that pharmacy. One challenge with these models is trying to separate the effects of multiple providers on a metric. Here, and I point out prescriber versus pharmacist and lowering hospital admissions. Maybe the prescriber is doing a really good job with prescribing, but then the pharmacist is helping them adhere to their therapy, and they're staying out of the hospital because of that. And who should get credit for it, or how is that allocated to the different providers? I think another spin on this is patients often go to more than one pharmacy. Is the one that they're getting the most prescriptions from really the one that's improving their care? That's reflected in the metrics that might be being followed. So again, they're not perfect, but these are the approaches that are being used right now. Another component of these models are performance measures. They're a central component since they're used to determine payment. A limitation of common metrics, I would say, is that they've been developed for other providers or programs other than community pharmacies. For example, Medicare Part D plan metrics are used for pharmacy performance, pharmacy plan performance, and some HEDIS measures are being used. Yet the HEDIS measures were developed for medical providers, but these value-based care models are using some HEDIS measures, like trying to close gaps in care is what they're calling that. So there's another component here is that these metrics commonly are focused on process rather than outcomes. So that's again a challenge to try to figure out, how much impact are these pharmacists really having? If you can't get to the outcomes, it's a tough thing. And then just for us to think about, one common metric for pharmacy that's often called medication adherence is proportion of days covered, or PDC, and these measures are calculated from dispensing claims. And as such, I think they're good measures of dispensing, but they're used to calculate like how many days, let's say out of the last 6 months, how many days did they have a medication on hand for them to take. So if they've had 100 out of 180 days covered, well, then that would be that proportion would be their proportion of days covered. So again, that's used commonly, but it really doesn't tell us like what the patients are doing, or what are they putting in their body. So it's potential medication adherence, or it's, like I said, it's dispensing, or maybe possession is another way to look at it. And then another component, incentives in these models. Incentives, we're talking about rewards and penalties for particular behaviors. Some of these incentives are not transparent, meaning that it's not easy for the pharmacist to determine what behaviors they actually did, or how the measures were calculated. Sometimes they are applied later on, like they're in a very retrospective approach. And again, that's a challenge, especially if you're trying to use these incentives to drive pharmacist behavior. Sometimes it's just not able to work. Another limitation of these current approaches is that many of the incentives are tied to dispensing payment rather than having a separate payment for distinct activities. And again, I think you can see how that could, kind of dampen their impact. Really doesn't help kind of drive the desired behavior by the pharmacist, or it becomes like a penalty that really shouldn't be there for this dispensing side. A third issue here is that the incentives can create conflict between high performance and best patient care. For example, the 90-day fill rate metric, which is used these days, can push the pharmacy to desire or try to approach having more 90-day fills for a patient, even if the particular patient might benefit from seeing a pharmacist every 30 days. Maybe the patient has an unstable condition, or they've been working with a pharmacist to really kind of keep touch on how the meds are working for them, how they're adhering, whatever the issues might be for that patient. And so putting them on a 90-day fill might not be the best for the patient. And so that creates a conflict for the pharmacy. And then last thing I'll just mention here about these models, there are pharmacy services, pharmacist care services, however you want to call that. I've just listed a few here: comprehensive medication management, medication adherence services. That adherence services might include packaging, in adherence packaging. It might include monitoring and interventions, a range of things that could be being done there. Pharmacy monitoring, social determinants of health identification and referrals. I know that's something that we're working on with the state here in Iowa from a CDC grant. And I think that's exciting to do that. Point of care testing is an emerging area as well. So we expect to see movement to use more metrics related to medication use and less about dispensing. I mean, that's a hope and an expectation. I think it will happen. All right, let's just do a quick knowledge check. So you can just put your answer in the chat. Which of the following is true about the components of value-based care models for pharmacy? It looks like we're getting a lot of D's there. All right, thank you for that. That looks good. I think we can move on. So all of these are part of the components I just talked about. All right, so now we're going to switch. So this is this is a value-based care model that we implemented and evaluated in Iowa. I call it the Wellmark Value-Based Pharmacy Program. The program involved Wellmark, which is Iowa's Blue Cross Blue Shield, 73 community pharmacies, and about 41,000 Wellmark beneficiaries were attributed to those pharmacies. It was a 3-year pilot. The first year was really kind of a startup year. The second year was a full year, and then the third year was about done, and then COVID hit. So this is actually finished up around about the time COVID started. But one nice thing about this, it was developed with a dialogue between Wellmark, their pharmacy administrators, and their medical director, and some other folks there, and Iowa pharmacy leaders. So it was really a kind of a collaborative development, which was great. So I think even though this was done before COVID, I'll just say that I think it was a well-designed program, and we have some pretty good evaluation data. That's why I wanted to talk about it today. So the evaluation from the pharmacy perspective was a collaboration between insurer. We also had Iowa Pharmacy Association, Drake University, and University of Iowa, and it was funded by the Community Pharmacy Foundation. And we had involvement with Iowa pharmacies. We had data from them, and then we also had performance data from Wellmark, which I think that was very great that they were able to share some of their performance data with us. So the objectives for evaluating the Wellmark program included describing the value-based pharmacy program implemented in Iowa. I'll spend some time doing that. Then discuss pharmacy's actions for patient care under the value-based pharmacy program using data collected in mixed methods through pharmacist interviews, followed by a mail survey. And then assess financial outcomes, and that's really where the Wellmark's performance data came in. So just get you a feel for some of the requirements for the pharmacies that participated. They had to have developed a service plan based on community-specific needs, offering at least 2 clinical services, adequate space for taking care of patients, documenting and communicating with providers, formal immunization protocol or collaborative practice agreement, and pharmacist training for service delivery and documentation. I look at those, and those really aren't a big bar for most of the pharmacies that are getting into this area. So I think that was good. It was interesting as we worked on this. We reached out to some of the national chains, and none of them wanted to participate at that time. So I think that was a missed opportunity by them. But again, they know what the bars really were for them, or how high it would have been for them to change, to participate. The program, I'm just going to touch on the metrics here. So the program had 18 metrics that address processes, surrogate outcomes, and outcomes. I'll show you some specific metrics in the next slide, but basically, they were trying to make sure that the patient was getting the right drug and were taking it. The surrogate outcomes, I think, were kind of unique because these were calculated from information submitted by the pharmacies. It wasn't claims data. They actually had to submit through secure online portal. I don't know exactly what the best term for that portal. Blood pressure readings, A1C readings, PHQ-9 scores. I thought that was great. Now I'll just comment on that. That was a challenge for the pharmacists to get these because they weren't collecting all those. Blood pressures they can take, A1Cs, for the most part, they needed to get from the clinics. And that was interesting because the clinics were like all of a sudden bombarded by, hey, these pharmacies are asking for these A1Cs and blood pressure. What more likely it was the A1Cs. And they had to figure it out. The pharmacies did get most of the providers to participate, but some providers really like, no, I'm not sending you this information. I don't really think you need it. And I think that's unfortunate, but again, that was the way it was at that point. And then the outcomes, I just want to also point out, this really was kind of the bottom line or the bread and butter from Wellmark's perspective. These are almost all, I guess I would say all utilization, but relate to costs, potentially preventable emergency department visits, admissions, and then total cost of care. Let me just talk about that. So again, I think that's the thing that really drove them to do this project, was really they wanted to find out, could having community pharmacists affect those bottom lines? And I'll show you some results in a little bit. Hopefully you can read that. That is a snapshot of the metrics. So this top set, this first kind of big cell here, those are metrics focused on the 4 focal chronic conditions for this program. And those are asthma, diabetes, depression, and cardiovascular. So it's really cardiovascular is like included hypertension, high cholesterol as well. They wanted to get them to take statin and then medications. So there, just to point this out, there were 42 points for these 15 metrics under chronic disease management. I'm not showing all of them. I just kind of did a little chop here. And then these are the utilization ones, and you can see the points. They add up to 58 points. So there was just these three for over half the points, and these points were used in calculating in the formula for how much they would get paid. And this was, I forgot to mention, this was a capitated program. It was not a fee for service program. So they basically had to have a score for each pharmacy based on the patients that were attributed to them using these metrics. And then those were used in their how much they got paid per person. So that also was pretty innovative, I thought, the capitated approach. So one last thing I'll say here, it was awesome to me that this total cost of care was included, because if you've been working in this area, you know that the PBMs or whoever was trying to put these programs initially, they were just all about drug stuff, all about trying to get the least expensive drug therapy for these patients. And that had been kind of like maxed out, at least in my opinion. Total cost of care recognizes that pharmacists helping patients take their medications, there's benefits that go to other areas of healthcare, right? They stay out of the hospital. They don't go to the ER. They don't have to see the physician as often. Maybe they don't have to take an additional drug because they're adhering, and the doc doesn't prescribe an additional one that they don't really need. Again, those types of things were in play, I think, by having this broader perspective. And I'll also say for these chronic disease management, only the patients with those diagnoses were included for scoring the respective one, like the asthma patients were for the asthma metrics and so on. But down here, the utilization, that included all the attributed patients that those pharmacies had. So they had some kind of healthier patients. And they had some ones that were very not healthy. So again, they had a range that they had to try to figure out how to manage. So methods of evaluation, today we have three different approaches. First, we'll talk about some highlights from a qualitative phase where we did interviews with 11 participating pharmacies. We recorded some phone interviews about their approaches to these sets of metrics, audio taped them and transcribed it, and then coded their responses to identify their approaches. Then we also used those responses or their transcripts to help develop items for a mailed survey that we did. In the first part, that we had 11 pharmacies that performed interviews. We did a mailing of all 73, and we were able to get data from 53. And then the analysis of the performance data, those were provided by Wellmark, and they of course had data on all 73. The survey, if I didn't mention it, that was focused mainly on 30 care-related actions and priorities that we wanted to find out. What did you do, or did you do this very often? That type of thing. And again, those actions were identified in the interview phase. All right, so let's look at some of the results here. And in the interviews, some common actions were addressing medication adherence. regularly tracking adherence during dispensing, addressing it through MedSync, adherence packaging, and so on. Then also, the value-based pharmacy program had a dashboard, which was providing some performance feedback, performance numbers for the pharmacies. They could see themselves and they could see the group. They couldn't see other pharmacies. Although unless there were some small change, they could see each other's. We found that utilizing was helpful, but not everybody was using it, and it was not the most user-friendly dashboard. So again, this was a pilot, so I think both sides were trying to figure out what's the best way to utilize this, make it available. Collecting lab and clinical data to monitor patients' progress was being done more often. They started out, like I said, it was tough. They didn't really know how to do it, but as more of them worked on it, they found some workable solutions, and then they shared that among the pharmacies. So I think that helped. IPA helped share some of that. CPSN Iowa was getting going later on in this study, and I think that helped as well. And then the pharmacies were improving and documenting their care. However, various platforms are used, multiple platforms at these pharmacies, and it's a challenge to always get the documentation as well as you want, at least in some pharmacies it is. Some less common actions. Some of them were coaching patients on appropriate emergency department use. They gave written materials along with some oral advice about, when they should be going to the ED versus calling their clinic or even calling the pharmacy. I know one pharmacy gave like a 24/7 number that the patients could contact them. I'm not sure how many late night calls they got, but I thought that was innovative. One pharmacy had a link to hospital's EHR to monitor for patient discharges to better be able to conduct timely med recs post-discharge, which I think that was awesome too. I think they still have that in place. And then another approach was sorting patients for different intensities of services. This helped sorting. They could target different activities, for example. They could use the clinical resource grouping scores that Wellmark has. They were using, I think it's a 3M product for the CRG, and that they were actually providing those back to the pharmacies through the dashboard, which is kind of helpful. Or other pharmacies I know were doing their own complexity or risk score calculations, maybe simply just looking at the number of medications and determining, above this cutoff number of meds, we're going to do a CMR or something like that. Again, this was not a fee for service, so they had to use kind of more of a population health management approach idea, like how do I sort this and allocate these limited resources that we're getting paid. For example, patients with a lesser risk or complexity, maybe they're just monitored for medication adherence or other problems that might be more common. And that last one, I'll just say that creating more time for pharmacists, I think really what's helped there has been the growth and greater uptake of medication synchronization. And again, that when we were doing this, it was out there, but it wasn't being widely used, or it's just used for just a portion of people. Now I think, especially among these pharmacies that did this type of project, they're using it widely. All right, so this is survey results here, and again, we see some similarities. They're doing some medication adherence monitoring here. It was pretty common. You see that scale on the bottom. 1 is never, and 5 is always. And so they're doing that for a fair amount of times, trying to get the lab data. Then we're educating about non-ER opportunities. And then utilizing electronic medical records. This was lower, as I mentioned, not all the clinics were open to that or even just even responding to faxes. So again, this was an area for improvement. We also asked them to prioritize these different areas that they might be focusing some of their work. And at the top, you see with the, kind of the highest, I guess it would call high priority on that scale, adherence and diabetes. And to me, those are not a surprise. I mean, especially adherence, that's been part of Medicare Part D, MTM, and star ratings for a long time, since, what is it, 2006. And so it's been going on, and that was comfortable for the pharmacists, these top ones. Then I think as you get down lower, kind of a surprise was total costs. I mean, total costs was a medium to low priority, yet as I pointed out, it was the highest component of score that directly affected their payment. I think one of the reasons that was so low is that we don't really have good literature on what's the best practices for community pharmacists to perform to affect total costs of care. I mean, I think there's more evidence that's needed. I mean, we tried to do some education for the pharmacists. Again, we didn't know. I mean, it's just not in the literature very well. Certainly wasn't at that point. But again, their focus on adherence wasn't a bad approach because that helped them sharpen that up. And it really is a good thing for the patients to be taking those medications. We asked them about some challenges, and this was the open-ended question we just coded. So this top one is kind of a lump, big chunk here. Staffing and time and workflow, those kind of all fit together to some degree. Task prioritization. Okay, I got all these meds to dispense, and you want me to spend some time with this patient. How do I handle that? There was some staff resistance. I think anytime you ask people to do something new at work, you can get pushback, right? And so that was happening. And then this second one, the state of Iowa has kind of stricter limitations for sharing information about patients' mental health. And so the legal at Wellmark said, we're not going to put any names in for depression patients. And so I think that was a reason that came up. They wanted to work on that, but they didn't know exactly who to work with. All right, so knowledge check. Which of the following is true about pharmacies implemented in Wellmark's value-based pharmacy program? I'll let you put that in there. See, we're getting some D's. Yeah, that's what I got too. So let's consider that correct. All right, let's move on. And we're going to actually stay with this value-based pharmacy program a little bit more, just to kind of continue the evaluation of it. This slide compares value-based pharmacy network pharmacies with themselves over time. So the bottom row shows that there were improvements in all four of these metrics. And these are some of the surrogate measures. Remember I talked the ones that they have to report from the pharmacy. And so you see from year one, about 2/3 were reporting it, and it inched up above 70 in year two. And then the control rate was going up a little bit. And then similar numbers for A1C, and not quite as high control to get people to 7.5. And again, these numbers, these cuts were agreed upon with Wellmark and the pharmacies. And I did put down here, the Healthy People 2020, 56% of people with diabetes were at goal. So they were getting in that range. They're getting a little better there. And then A1C, this was a goal at 7, so can't directly compare, but probably getting close, maybe not quite as good as nationally, but it's some improvement within this population of patients, though. So I think overall this shows some impact by the pharmacies. And now I just want to look at the analysis for the financial outcomes. So generalized linear models compared outcomes for patients in the value-based pharmacy program versus not. Inclusion criteria, at least one chronic condition, continuous membership, continuous attribution. And then we had some control variables, ACO attribution, then this was for Wellmark's ACO. We had the clinical resource group, risk adjustment, 3M health status, geography, and this was just regions. Actually, I think this was the states because we had Iowa and we had a few people in South Dakota. And then HMO, PPO membership. So just to give you some numbers, when you apply these inclusion criteria, value-based pharmacies, those had 15,000, just over 15,000 patients. And the non-value-based pharmacies, that had 140,000 patients. So a lot more patients, as you might expect. It was not the whole state. It was not all the pharmacies. So this slide shows the results of analyses of the three financial outcomes: total cost of care, hospital admission rates, and emergency department visits. And you can see that the mean total cost of care for the value-based pharmacy group was 4.5% lower than those in the non-value-based pharmacy group, while controlling for those other variables I just mentioned. Hospital rates and ED visits were lower, but they weren't statistically significant since their confidence interval crossed 0. Put this 4.5% in perspective. It was about $30 per member per month difference, which is nice. This is after they paid the pharmacies, which is, I think the estimate I saw, or the numbers I saw, were about $1 million a year, something like that. This slide shows the effect of the value-based program over time. This is our 4.5% here in year 2, which is 2018. It's the first full year. And then this launched, but it wasn't cleanly launched at the beginning of 2017, but they gave us some numbers there. So you can see that when it started, or at baseline, it was a little bit lower cost for the value-based pharmacy group. But then as they started operating the program, they pushed it down. And again, this is interesting that it started to go up, but I didn't get the final numbers. Like I said, the COVID came and I never ended up getting the last of these numbers to update this slide. But again, you see definitely some movement down, which is great. This slide shows the return on investment for the value-based pharmacy program, and this was calculated by their analysts at Wellmark. Return on investment of 9 times, which is very good. You see the strongest effects were reductions in total cost of care. And at this point, we were optimistic that this program would be expanded. Then COVID hit and it was not changed. It was kind of like held steady. Was not expanded. So recap and recommendation. Members using the participating pharmacies in this program had 4.5% lower costs of care. And we estimated that Wellmark saved about $15 million during 2018 by having this value-based program implemented just for a fraction of their beneficiaries. They have over 1 million beneficiaries in Iowa. I think it's close to 2 million. Since we've done this evaluation, the leaders at Wellmark have changed, so the individuals are gone, and the new people are less supportive of the program, and they really have just kind of like stopped it. Like they're coming in more from a PBM perspective than an insurer perspective, and they want the pharmacists to do stuff like medication switches and all this other stuff that affects their rebates and doesn't really help the patient's health and may not help their total cost of care either. However, though this is kind of discouraging, Iowa pharmacy leaders continue to meet with Wellmark administrators, and hopefully that we're going to get this rejuvenated. I mean, it did have some impressive financial results. So one more knowledge check. Which of the following is true about financial outcomes of the pilot of Wellmark's value-based pharmacy program? Yeah, when we see B's, that's good. Thank you. So yes, correct. There were significant savings in total cost of care. All right. We continue here. Now I want to shift to an ongoing value-based care model in Iowa. I have less information about this program, but I wanted to share it since it's currently being implemented and expanded, which is great. I think it's a good example of what can be done with some state Medicaid plans. It's focused on high-risk Medicaid beneficiaries, those that are taking medications for behavioral health, asthma, COPD, and opioids. Pharmacist provides an initial med review and then does monthly follow-up visits. I'm happy to say there was kind of a holistic approach, though, where the pharmacists have various actions they can take to help the patient, including medication management, health coaching and screenings, care navigation, provider engagement. They did not have to focus only on the 4 conditions used for eligibility. Again, I think that's a great approach to this because we don't really know what the patient needs are when they get into this and what the pharmacist sees. Some of those programs that just use dispensing data to direct care, I think, have a limitation in that way. So this is being done in 18 pharmacies, over 800 eligible beneficiaries. So it's a much smaller program. They ran it for 2 years, with the first year being some run up or kind of get it going. Evaluation used a retrospective propensity score analysis. In the second year, 848 people in each group, matched on age, gender, risk score, and the 17 most frequent costly chronic conditions and baseline medical costs. So they were trying to compare groups that they thought were pretty equal. And then just got some snapshots of some of their results. And I say they because I did not do these results. This is Lindsay Ludwig shared this with me, and she's the executive director of CPS in Iowa. They're the ones that are working with Elevance, which is the PBM that's coordinating this program and for Iowa Medicaid. So this slide shows comparison of types of medical utilization between engaged patients, which the ones that were in the program, and the match group of those not in the program. The blue bars here are the pre-post differences for the non-engaged group, while the aqua bars are the pre-post for those in the pharmacy program, and the orange bars show the difference in differences. So you can see all for the patients not in the program, these costs or these utilization increased for all these. For some of the, like especially for inpatient, there was a significant reduction. This star here shows that it was statistically significant. It was the only one that they found that, but it was a pretty good reduction, 33% reduction or difference. Then also there's some HEDIS measures, as I mentioned before. The same thing here, the dark blue is the non-pharmacy group and the aqua is the pharmacy group. These are looking to kind of close gaps of care, behavioral med, prescription and compliance. How are they doing in their acute phase? And medication-assisted therapies. This is opioid-related here. And then you have some more related to schizophrenia management or medication and management. So here the stars indicate just that it's a HEDIS measure. They were not, it says the gap closure trends appear favorable. The small sample size for many measures made it impossible to determine statistical significance. So again, we don't know exactly how significant these are, but I wanted to show this. I just think it's gives you an idea like how these plans are thinking. What are they trying? They're trying to get these pharmacists to help with these types of issues. I was interested about this medication-assisted therapy, what happened there, and I think that that's helping them identify patients that would benefit from medication-assisted therapy. Comparison of costs. Again, same type of thing. The dark blue are costs for the non-pharmacy group, and the aqua are costs for the pharmacy. So I want to draw your attention here to pharmacy costs here. This was statistically significant difference that actually the costs for pharmacy group were higher. And again, but they showed some good reductions in many of the medical costs. So this to me, one interpretation is that by getting these patients to take their medications, that's helping them avoid some of these medical costs. I'm sure that's not all what these pharmacists were doing, but I know that that's an important part of what they're doing. I don't have more data on this particular program right now, but I think it's consistent with what we saw in the Wellmark program, right? They were working on medication adherence, and it was affecting other costs. So I want to talk with Lindsay Ludwig about doing further evaluation on this, because I think that there's some interesting questions that need further investigation. And as I mentioned, she said that this is being expanded to more pharmacies. She has about 120 pharmacy members. I don't know how many are actually involved in the expanded phase. But again, I think it was by dozens more pharmacies. Last knowledge check. Which of the following is true about evaluation of the Iowa Medicaid pharmacy program? Actually, I see that, this should be utilization, but I think the costs were there too, because that was there. A is the correct answer here. All right. How are we doing on time? I think we're tight on time. I think I'm just going to stop here. I do have some lessons learned. And I think bottom line is that they were able to the community pharmacists were able to improve outcomes and costs. There were definitely had some challenges of how to get things done, workflow, staffing, IT were challenges. Some providers weren't quite ready to work with them. Tracking and feedback seemed to be helpful, but again, wasn't used by all. There was some pushback by patient, not a lot, but again, there was some learning. I think this is a future research that, that we need to know what activities are going to improve patient outcomes and costs. And then separate payments would be useful. So I think there's some promise here. Let me just go to question